Hi everybody, I am Milena Foerster from the IAC in Lyon, and I'm happy to present you my latest work on breast cancer management in the African breast cancer disparities in outcomes. I start with a quick introduction. One of the three main pillars of the Global Breast Cancer Initiative is to provide comprehensive breast cancer management to improve breast cancer survival worldwide. However, breast cancer management in sub-Saharan Africa is challenging. Oncological facilities and infrastructure are scarce, or not all countries provide universal health coverage. Taking this into account, the NCCN developed resource-stratified harmonized guidelines to provide timely and quality treatment in sub-Saharan Africa. But to date, high-quality quantitative comprehensive data on breast cancer treatment in sub-Saharan Africa is scarce. Here we present benchmark estimates of breast cancer treatment from the ABC-DO study, mutually evaluating guidelines adherence. Our study design in short, the ABC-DO study is a prospective breast cancer cohort in 5 sub-Saharan Africa, listed here in green. ABC-DO follows up over 2,000 patients via 3 monthly phone calls since 2015. As an asset, ABC-DO uses mHealth, which led to only minimal losses to follow up. In the present analysis, we look at the treatment data, which was collected from both follow-up questionnaires and clinical records. I come straight to the results. The NCCN harmonized guidelines tailor individual treatment, at least on histological type, breast cancer stage, ER/PR status, tumor size, and positive notes. This is very important to notice because in ABC-DO, many of these factors are in fact often unknown, including stage and most notably the ER/PR status, which is only known in 3 out of 5 countries on a routine basis. This makes it often a priori impossible to adhere to these guidelines. We defined potentially curative treatment for breast cancer as receiving at least surgery and systemic treatment. In total, this was received by 61% of all non-metastatic women in ABC-DO. As expected, this proportion was considerably lower in women with advanced disease, which are not displayed here. A major finding are the pronounced between country differences. Here are only 2 examples, Namibia on the left and Nigeria on the right. The major difference here is that in Namibia, as also in South Africa, universal health coverage is provided, whereas in Nigeria, such as in Uganda and Zambia, it is not. Accordingly, a high percentage of women did not initiate any treatment in Nigeria, as displayed by the green circle on the right. Additionally, only about 40% of women in Nigeria initiate potentially curative treatment, as you can see on these large gray, orange, and turquoise areas on the graph on the right. As I highlighted in my first publication on treatment access, out-of-pocket treatment costs are the most important factor contributing. Some more findings in brief. 75% of all women initiating treatment did this within 3 months after diagnosis. However, as you can see on the graph on the left, this was driven by women in South Africa and Namibia, as only few Nigerian, Ugandan, and Zambian women received timely treatment. We found also a high proportion of women initiating neoadjuvant systemic therapy without ever receiving surgery after. As these were high and locally advanced compared to localized tumors, this might be due to understaging, but also non-effective systemic treatment, as ER and PR status are often unknown. Treatment completion rates are low. Only about half of all women initiating chemotherapy completed also the treatment, which was defined as receiving at least 5 treatment cycles. And finally, proper lymph node management after surgery and radiotherapy treatment are absolutely necessary to prevent local recurrence, but both are rare practices in our cohort. Some conclusions. Comprehensive breast cancer treatment is not provided to all breast cancer patients in sub-Saharan Africa. We saw between country differences in ABC-DO. There is need to improve diagnostic workup, in particular IHC testing and TNM staging, and most importantly, universal health coverage is key to provide life-saving treatment to breast cancer. I dedicate this to Dr. Charles Elisa, our friend and ABC Do co-PI who recently passed away, and please contact me for further questions.